Now, here's some other things that you can do, but not required. I don't like this test because, again, this is two-point discrimination, and it has to do with how sensitive that part of the body is. So 2 points can be felt a lot closer on your finger, where the nerves, there's lots of nerve endings, as compared to out on your shin, where there's not as many nerve endings in that per amount of skin. So I think this is a waste of time. I don't do it. You could do it if you wanted to, but it's called two-point discrimination. And then other things that put you in the cortex, so many times people have this as a cortical lesion, is they have what's called stereoagnosis or agraphesthesia. So stereoagnosis is the ability to actually be blindfolded, and they put something in your hand, and you can feel it in your hand, and you could be able to identify what it is, like a coin or a key, okay? Because it's putting a lot of sensations and textures together to be able to identify it. Graphesthesia is the person has their eyes closed, and you draw a letter or a number in their palm, and they should be able to tell you what the letter or number is. Okay? So these, many times when you see these only, you're dealing with a problem out in the parietal lobe. Okay? All right, next. Coordination. And we write finger to nose and heel to shin, normal. You could also do finger taps and rapid alternating movements, normal, but those are optional. Okay. Now notice I do not call this the cerebellar exam, because once again you can be uncoordinated and it has nothing to do with your cerebellum, although most of the time it does, but not always. So we do not call this the cerebellar exam, we call it the coordination exam. And once again, remember the cerebellum. I've had a lecture on this, and we're talking primarily about the neocerebellum for the most part when you have a problem with coordination, which we refer to as ataxia or dysmetria. Dysmetria usually of the hands, ataxia usually of the gait. And so I need another volunteer. Hurry, someone, please. Why don't you come up? So, I want you to take this finger right here and touch your nose, and then touch my finger. Okay, go back to your nose, go back to my finger, go back to your nose, go back to my finger. Am I doing it right? Seems like it's right. Actually, I'm not, because I really have to stress the patient, all right? Stress their cerebellum, not, I'm going to kill you, no. Take this finger, touch your nose. This is how I stress him. Now, touch my finger, okay? Back to your nose, back to my finger, back to your nose, back to my finger, okay? So if he had dysmetria, he may miss the target. So that's called hypometria if you don't get far enough, or if you pass it, that's called pass pointing or hypermetria. Or sometimes when you can't quite get to the target and you're kind of, that's called an intention tremor, okay? So you may see these things, but if you don't stress them, they may be pretty accurate close up. You really need to make them stretch, and you have to give them a couple of targets, okay? Very good. Heel to shin. I'm not done with you. Not yet. Okay, now, most of the neurological exam can be done with the person sitting, but there are two parts that really should be done with the person supine if you can, and this is one of them. So I want you to get supine, all right? Very good. All right. And the reason why it's better with the person supine is that when you're laying down, you can't really see this maneuver. So he's using proprioception to get him for his accuracy. I want you to take this heel to bring it up to this knee. Okay, and with him laying there, he can't see that. Now, if you had to do it with the person sitting, you'd probably have them do it with their eyes closed. He can't see his knee when he's laying there. See what I'm saying? So without the eyes and just using his coordination, if he doesn't know where his knee is, he may be like doing, whoa, where am I here? Oh, finally I'll get it. Okay? And then slide it down, and then slide it back up, and then slide it down again. Be nice and smooth and slide it back up. If he has a cerebellar lesion, he'd be all over the map here. Okay? Now, there's one other thing that should be done with the person supine, and I skipped it. I actually did it on you, but I didn't finish doing you. What did I do on you? Muscle tone of your arms, but I didn't check the muscle tone of your legs, did I? Can you be spastic in your legs and normal in your arms? Yeah. Where would the lesion be? In your spinal cord. Okay. So with him supine, this is a good way to test the tone of the legs, and this is how you do it. Again, he has to be relaxed. I'm just going to go behind your knee here. Let's show you on this side so you can show it better. All right? And then when he's not expecting it, I just pull up. And what happens is, as you saw, his heel drug on the bed. All right? Now I want you to make this a little stiff. So let's say he was spastic instead. That's what I'd get. Okay? His heel would pop off the bed. Thank you very much. Very good. All right, so it really should be done, if possible, do it with the patient supine. Oh, here's another one that's a cerebellar exam, but I think this is cruel. I never do this to anybody. But you have them, hold, and then you let go, and they punch themselves in the face unless you put your arm there to protect, So you let go, and they're supposed to be able to stop, and that arm there is to prevent them from hitting themselves in the face. You don't need to do that, but it's one of the tests that is sometimes recommended in books. Oh, here's the finger taps here. Again, we do this with a Parkinson patient. Many times, again, they'll grind to a halt, as you saw when we did our Parkinson patients. And then the rapid alternating movements is back, forth, back, forth, back, forth, back, forth, like this. Okay? So these are additional things that you can do if you're not quite sure, if you've just done the finger to nose and heel to shin, whether they have a coordination problem or not. Okay, next, deep tendon reflexes. And we write 2 symmetric throughout plantar response normal. No, I'm sorry, plantar response we say flexor, which is normal. Okay. Now, of course, we need to hit somebody with a hammer, and you have all different types of hammers. Okay. So you see, here's 2. The thing about hammers is, the longer the handle, or the heavier the hammer, the better it works. Okay. So these, you can see, are very long handles. This is a retractable one. They're called Queen's Square hammers, because they were invented in Queen's Square in London. This is called a Tromner. Okay. And you have a little tomahawk, and you usually get them for free because they're useless. And then you have this one. I love this hammer. It has a little brushy brush on one end, which tells you nothing. And then it has a little pin that's stuck in the thing so that you can poke somebody with hepatitis, and then you can give it to your next person and give them hepatitis, and then you can share the love, So, when we're saying that 2 symmetric throughout, this is what we're after. We're looking again at levels. This is the minimum that you have to do. Actually, the triceps is optional. And rather than writing it out like this, another thing that you can do that I'm sure you've seen is to draw the little stick man, although I always have a problem with him. Anyway, so you would do 2, 2, 2, 2, 2, 2, 2, 2, and the plantar response being normal would be arrows going down, flexor. The toes should flex. Okay? And again, each one of these responses, each one of these reflexes are assigned to a level. So if you have a pinched nerve in C7, you may notice that the tricep on that side would be decreased. Okay? So rather than 0 to 5, the reflexes are 0 to 4. 0, 1, 2, 3, 4. And instead of 5 being normal, 2 is normal. Okay? So what does that mean? Well, that means 1 is decreased and 3 is increased. 0 is nothing, and 4 is increased with clonus. Well, believe it or not, there's only 2 instances that are always pathologic. And what are they? Guess. 0 and 4. That you got it half right. 4 is always pathologic. If you see sustained clonus, that's pathologic. That's usually seen with spasticity. Okay? 0 isn't necessarily always abnormal because you can have our reflexes go down as we get older. So if you have a little 80-year-old man and you're testing his ankle reflex and you get a 0, I'm not too worried about that. You get a young person with 0s throughout, I'd be worried about that. But what's the other thing that we're always looking for on the neuro exam that's pathologic many times? Asymmetry, very good, whoever you are, okay? Absolutely. So if you hit one knee and you get a 2, and you hit the other knee and you get a 3, one of those is abnormal, okay? Asymmetry is always pathologic, all right? Volunteer. All right. So again, we have many choices, but I'm going to use the trometer. Slide out here just a little bit more. So, all right, so everybody can see. Now, first thing we're going to do is the bicep. The bicep is the one where you're not going to hit the patient, you're going to hit yourself. So what you do is, the other thing is that the reflex that you're looking at, that the joint that you're looking at also always has to be slightly flexed, okay? And the person has to be relaxed. So relax, there you go. And I'm going to feel for his bicep tendon, and you could feel it for it in yourself, okay? So we're looking for that bicep tendon. Try and put your finger on it, and then you hit your finger. Okay? And you see that he's moving a little bit, but not much. And I actually feel it under my finger, his bicep jumping. So I would call that a 1. And as long as his other side is a 1, I don't have a problem with it. Okay? Next is brachioradialis. All right? So above the thumb, again, we want to flex a little bit here. Relax this hand. Just let it lay there. Oh, that's a good one. Did you see that? So that's a nice 2. All right? So that's brachioradialis. Again, that's C5. Now, tricep is an optional one. You have to hang like a scarecrow. So hang like a scarecrow over here. No, just this is one arm. All right? Just let it lay in my arm. Okay, let's see what we get. Oh, there we go. See that? So that's testing C7. All right? Now, knee or patella. What you do is, if you're not quite sure where to hit, you feel for the bony patella, and then you slide your fingers down where you don't feel it anymore, and then you hit in between your fingers. Ooh, that's a nice one. Okay, so that maybe we want to call that a 3. Okay, but again, if the other side is a 3, I don't have a problem with it. Okay, many times in a person who is young and healthy and in good shape, that we see 3s throughout, and that's fine. But the average is a 2. And then finally is the ankle reflex, the Achilles. And again, relax this foot. And again, I have to dorsiflex it a little bit. Good, you see that? Okay, really good. All right. Now, to check for clonus, I grab his foot and I jam it up. Okay. And if he was spastic, upper motor neuron problems, he would have hyperactive reflexes throughout, but he would also have this thing called clonus, and his foot would continuously do this. Okay? So when you get to neurology and you see somebody who has had a stroke, past stroke, that they may have this. In addition, the Babinski sign, now his shoe and sock would be off, the plantar response. And you scrape the bottom of the foot and then go over the sole, and the normal response should be that his toes should go down. So that's the plantar response is flexor. Thank you much. Appreciate it. Give him a hand. So again, these are just pictures of what we've done already. And they're using that horrible tomahawk that doesn't work, or works very poorly, I think. There's the bicep. There's tricep. There's your knee, and you can do it with a person, let's say if they're paralyzed and they can't really sit up, you have to actually flex again. You have to put your hand underneath in order to get the response. And then the Achilles, the person who can't sit up, you have to do it laying down. Again, you have to flex in order to get the response. And here's the plantar response, where you scratch the bottom of the foot. Again, most of these hammers will have a little sharp edge on it, and that's what you use to scratch the bottom of the foot with. Start at the lateral aspect of the foot, and then you go over the sole, and the toes should go down. that's the plantar response is flexor. Or, as in this person, look, his toe is going up, right? So you can call that the plantar response is extensor, or you can call this that he has a Babinski sign. Okay, so this is actually a reemergent a reflex that is seen in babies that goes away and comes back if you're spastic. Okay, so if you scratch the bottom of a baby's foot, you'll get this, and that's normal, but that should go away. And if it comes back in an adult, that's called that's most likely related to spasticity. All right, so now sometimes a person cannot relax. As a result, you're tapping them and you're getting zeros. So you're thud, thud, thud as you're hitting them, you know, and it's because they won't relax. So for those people, we do what's called a gendrastic maneuver. So if you can get their mind off of it, then you can trick them, basically. So here's a person who is, I have him pull his arms real tight, and he's looking up at the ceiling, and he's counting backward from 100. 100, 99, 98, 97. He's looking at that light up there, and he's counting, and he's concentrating on that. And while he's doing that, when he's not expecting it, then I whack him. Okay? And many times, you know, this 0 turns into a 2, you know, and that's called a gendrastic maneuver. So never settle for a 0. You have to do a gendrastic maneuver to prove that it's a 0. And a young person like this should never have a 0. There is a bad disease, Guillain-Barré syndrome, okay, which is a peripheral nerve disease that is a demyelinating disease that could kill you. And the first thing that happens is they lose all their reflexes. And in a young person, if you lose all your reflexes and then start to get weak, and it happens really quickly, it could kill you. All right? So spasticity is a judgment call. Usually the person will have increased velocity-dependent muscle tone. They may have a positive clasp knife reflex in their arm. They have increased deep tendon reflexes throughout. And if it's really severe, they'll have clonus in their ankles. And they may have a positive Babinski sign. The more these things a person has, the more likely they're spastic, and meaning they're more likely they have upper motor neuron disease. And of course, in Lou Gehrig's disease, not only do they have lower motor neuron disease, but they have upper motor neuron disease also. Okay, so you will see, you know, these spastic things on exam, as well as the lower motor neuron stuff. Again, this is the way to elicit clonus. And again, it's a perpetual motion machine where the ankle will go bup, 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 like this, okay? And that is always abnormal. Now, in a young person, if you jam it up and you get one beat of one beat of clonus or 2 beats of clonus, that can be normal. But if it's pretty much sustained, you know, anything above a beat or 2, then that is abnormal. Right? Then there's another test called the Hoffman test. And this is a test that is optional. It's believed to kind of be the Babinski of the hand, okay? And you flick the middle finger, and what will happen is that the index finger and thumb will pinch. So you grab their hand and you kind of pinch or flick that middle finger, and nothing should happen with these 2 fingers. But if they do that, that's called the Hoffman sign. All right, and then finally, the last part of the neuro exam. Yay! Number 7, gait. And we write normal, good tandem, negative Romberg sign. All right? So, do you remember the story about Romberg? He was a Prussian physician in the 1600s or something like that for the Prussian army. And he could predict which ones of his soldiers had neurosyphilis, because he'd line them up at attention and have them close their eyes, and the ones that fell over had syphilis. Because in those days, again, they didn't have penicillin, and the syphilis could spread to the dorsal columns. They lose their proprioception, so they don't know where the floor is, and they fall over. And that's his claim to fame. Now, how much do we see neurosyphilis these days? Not very often. So why are we still doing the Romberg sign? Because there are other things that could cause a positive Romberg sign, such as if your nerves don't work. Right? You take your eyes away, And your brain is relying on your proprioceptive information from the nerve endings in your feet to tell you that you're flat on the floor and you have nothing to worry about. But if those nerves are damaged, as in, let's say, diabetic neuropathy, person could be, ooh, they're not quite steady, and ooh, I'm scared. And next thing you know, they're doing this, okay? And that's a positive Romberg sign. Now, when you have somebody walk, you need to watch them, the whole thing, okay? So you have them walk, and then you have them turn around. And pretty normal, right? Right? Pretty normal? I'm not normal? Well, someone may have noticed that I wasn't swinging my left arm, okay? So you not only look at the person's feet, you look at the whole body, okay, including their stance. You know, this kind of stance is not normal, okay? This kind of stance is not normal. You know, this kind of walking, that's not even normal in Texas. All right? That's called a wide-base gait, okay? And they do that because if they walk normally, they'd fall down. They're widening their stance to give them more stability, okay? So you look at the whole person. Not swinging an arm, that could be the first signs of Parkinson's disease, okay? There's the Romberg sign. So you should be able to do that without falling over. And then the tandem. So the tandem is, you can't let them cheat for a tandem. So you have to have them touch their heel to their toe. I don't care if their arms are up or down. I don't care about their arms. They just have to touch their heel to their toe and be able to walk the line. Okay? Now let's say your patient is 500 pounds. Legs are like this, and there's just no way that he can do it. So what do you write? You don't write anything? If you don't write it, you didn't do it, okay? So what do you write? Tandem not tested due to body habitus. Okay, now I know that you tried to get him to do it, but this is the reason why he couldn't do it, and so you're covered. So don't skip anything, all right? And document everything. Very important. Now, you can get different kinds of gait, all right? Again, we talked about the ataxic, you know, cerebellar drunken gait, all right? And the apractic gait, where the person is stuck on the floor, you know, sometimes seen in Parkinson's disease, but more so a lot of times seen with normal pressure hydrocephalus. The scissors gait, where the person is like a scissor, they're doing this, because they're spastic in both legs, okay? The spastic gait, hemispastic gait, where they only do that on one side, so they're doing this. Then you have the steppage gait, which is like a show horse. They're picking their feet up really high because they have a foot drop. And if they just tried to walk, they'd be dragging that foot. So they pick up their foot really high so that they're not dragging this foot. Okay, that's called the steppage gait. And then the Parkinson gait we talked about. And if they have something else, you just try to describe. They walk with a limp, they use a cane, whatever. Again, some of these spastic hemiparesis, again, they're swinging that leg around. And if the scissors gait is when both legs are spastic, and so they're swinging both legs around, and it's like a scissors, okay? And then the steppage gait, where they have a drop foot, and they're picking that leg up so that they don't drag that foot on the ground while they're trying to walk. What about this guy? This picture is consistent with what? His gait is not normal, is it? That's Parkinson's disease. Now, there are some other additional maneuvers that I need to just introduce to you because you're going to be using them in the emergency room, okay? And they're not part of the classic neuro exam, but you're definitely going to use them, okay? And maybe you've seen a couple of these already. I just want to go over them. If a person may have meningitis, they may have a positive Koenig's or Brzezinski sign, okay? If a person has had a stroke and they may be thromboembolic stroke, you certainly want to auscultate their heart and carotids. You may hear an abnormal heartbeat, or you may hear a stenosis, which will cause what's called a bruit in the carotid bifurcation. Okay? Lermite sign is a sign that's sometimes seen with multiple sclerosis, where the dorsal column is demyelinated and some proprioceptive information winds up in the spinothalamic tract, and you can elicit it by having the person touch their chin to their chest, and that should be just a proprioceptive move. But instead it's a painful move because, again, the proprioceptive information goes into the spinothalamic tract, so they do, oh, when they do, that's called a positive Lermite sign. It's like electricity running down their back when they do this maneuver. Okay? Tunnel and Phelan sign is for common problem in the person's hands, which is called carpal tunnel syndrome, and I'll show you how to do that in a second. Also, we do some things when we're suspecting hysteria in a patient. Okay? So you have the person who says, "Oh, my face is numb on this side. I can't feel a thing," you know, and they're hysterical, you know. And so we do a thing called splitting the forehead to vibration. So remember, when you hit a tuning fork and put it on their skull, that vibratory sense is going to go throughout the skull. So you cannot split the forehead. So if you suspect that the person is hysterical, you go to the good side and they say, "Yes, I can feel the vibration here." And then you go to the bad side and they say, "No, I can't feel it." Well, that's not right. Okay? Because again, vibration goes throughout the entire skull, so there's no way, no matter where you put that tuning fork, they're going to feel it. Okay? So that's called splitting the forehead. Then Lessig sign is a sign that is seen with a very common thing in the emergency room where people are complaining of a possible radiculopathy, where they have a pinched nerve in their back and it's causing shooting pain down their leg. This is a maneuver that you're going to do to prove that it's consistent with a radiculopathy, because some people fake that because they want narcotics. They go in the emergency room, they go to another emergency room, and there's, "Oh, my backache," and they're getting Lortab from everybody there wherever they go. And then another thing called Hoover sign, where a person is pretending that they're paralyzed in their legs. So let me show you some of these. So this is the person with meningitis, and Koenig sign is where they want to stay stiff, because any movement or stretching of the meninges is going to cause a painful sensation. So an adult, we usually do this in an adult, we bend their hip and then stretch their leg, and that's stretching the nerves in their legs, which are connected to the dura that's in their cord, and they won't let you do that. Okay? This will be a very painful maneuver, and that's called Koenig sign. Now, this other one, Brudzinski sign, many times done in a kid, but it could be done in an adult also. We have the child lay flat, and you move their head toward their chin, and to relieve the pressure off their spinal cord, they'll reflexively flex their legs, okay? So rather than just leave their legs flat, okay? And that's called Brudzinski sign. Again, another sign that the person may have meningitis. This is Tunnel's sign and Phelan's sign, which is there's a nerve, the median nerve that goes into your hand can get pinched at the level of the wrist. And so when you tap there, that's called Tunnel's sign. And if you tap on it, and oh, they get a funny sensation in these three fingers, that's a positive Tunnel sign. Positive Phelan sign is they put their hands like this and they move up and down, and they get, oh, that's a weird sensation in my hand, okay? Which meaning, again, that the radial nerve, the median nerve is being pinched at the level of the wrist. It may require surgery to release it, okay? Again, very common problem is you can get a slip disc, as they call it, and some of it can herniate out and push on one of these rootlets that is exiting the spinal cord, and it can cause weakness at a level. Most commonly, though, it causes pain, and it's shooting pain down your leg, okay? And that we refer to as radiculopathy. And the one way to figure it out is to do what's called the Lessig sign, or the straight leg raise. So you have the person lie flat, and you raise that leg, and if you do that, and then if you dorsiflex the foot even more, if you want to stress it more, they will complain of a shooting pain going down that leg if you do that. Now, some people know this part, okay? But then what you do, if you're suspecting that the person is lying to you, you have them sit up, okay? And then you pretend like you're checking their knee out, and when they're not watching, you stretch that leg out. And they should, that's the sitting Lessig sign, and they should go, oh, you know. But if you're allowed to do that, you kind of fake them out, and you stretch that leg out, and they're not complaining, then what they were complaining laying down is BS, okay? So you got to do the Lessig sign with the person laying, and if you're suspicious, you also try to do it with the person sitting, okay? Sometimes patients lie to you. And then, of course, the Hoover sign, which is a person pretending that they're paralyzed in their legs. So you put your palms under both heels, and you ask them to try and lift their leg, okay? And what should happen is that if they're really trying hard to, let's say, lift this right leg, they will shift their weight at their hip over, and what will happen is that they will push down on this side in order to try to lift this side. And you'll feel that if you put your hand underneath this heel, you should feel a pushing down of the heel if the person is really trying. If you feel nothing, then that person's not trying at all, and that's called Hoover's sign. Okay? You're getting sucked in if you fall for Hoover's sign. And then after you've done your examination and you suspect that there's a lesion somewhere, you confirm it with a myriad of tests that you have at your disposal. Okay, whether it be an imaging test like an MRI or neuropsychological testing, or you have to do a lumbar puncture, or if you suspect seizures, you do an EEG. You do the appropriate test, okay, and those are all listed here. And that's it. Thank you for your attention.